Hello and welcome to the Imaging Wire Show. My name is Brian Casey and I'm managing editor of the Imaging Wire. Got a really special episode for you today. Our topic is new developments in breast density. Our understanding of breast tissue density and its relationship to cancer risk has advanced greatly in the last 2 decades, to the point where the U.S. government in March 2023 announced that it would require all women appearing for mammography screening to be informed of their breast density status. At the same time, new models such as the Tyrer-Cuzick model have been developed to better calculate a woman's risk of breast cancer and potentially guide screening decisions. Today, we're going to be talking about the relationship between breast density and cancer risk, and I'm really excited to be welcoming our 2 guests. Jack Cuzick, PhD, is professor of epidemiology and former director of the Wolfson Institute of Preventive Medicine in London. Dr. Cuzick, along with Dr. Jonathan Tyrer, developed the Tyrer-Cuzick model, which measures an individual's risk of developing breast cancer. We also have with us Dr. Stamatia Destounis, a radiologist and managing partner of Elizabeth Wendy Breast Care in Rochester, New York. Dr. Destounis is well known for her clinical and research work on many topics in breast imaging, including CAD, digital breast tomosynthesis, breast ultrasound screening, and breast MRI. She has a special interest in genetics and risk assessment, and Elizabeth Wendy has had a genetic counselor on staff for over 13 years. It's also one of the busiest outpatient genetics risk assessment clinics in the country. Dr. Destounis, Dr. Cuzick, thanks for being with us today.
Thank you.
So let's start with introductions. Dr. Cuzick, can you tell us a little bit about yourself and kind of what you've been doing for the last few years?
Sure. Yeah, I'm basically I'm trained as a mathematician, but I've got very involved for the last 40 years in terms of medical problems. So I've been doing a lot of work in terms of clinical trials and studies. And I guess the thing that interested me is sort of being on the boundary between 2 subjects. So I ended up being partly in clinical trials and partly in epidemiology. And the obvious place for that was prevention. So I've done a lot of work on breast cancer prevention, and we ran the 2 major trials, one on tamoxifen for high-risk women, and then more recently, although 10 years now, with the aromatase inhibitor anastrozole, and showed that anastrozole is a highly effective way of actually preventing breast cancer.
Great. Dr. Destounis, how about you?
For the last several years, we've been very active, a very busy practice in upstate New York. And we provide care in urban, kind of suburban, and also rural areas to patients that don't necessarily have access to care. Some of our centers are, one of our centers is over 2 hours away. And so what we've been very interested in is obviously the latest technology and utilizing that, and also how to, incorporate clinical research into what we're doing every day. We've done a lot of work with breast density and how that, correlates to risk for patients for breast cancer. We have a very active genetics and risk assessment program. And, we've been very excited to be able to test, do genetic testing for several women that are high risk and bring their families in also, and continue to screen them with supplemental screening after we identify them.
Great. So let's talk a little bit about this idea of breast density, and then we'll talk about risk assessment in a little bit. But basically what we've come to understand in the last maybe 20 years or so is that a woman's, the density of her breast tissue can be a factor in terms of her cancer risk. Dr. Destounis, can you talk a little bit about that and what exactly we know?
Well, we've done a lot of work on this, and so have several other researchers, that, breast density, it stands on its own as an independent risk factor for breast cancer. And predominantly, we've all been aware, through our different classifications of breast density on the mammogram, that the more fatty patterns, the less dense patterns, are much easier to interpret for the radiologist, and we're more accurate, more sensitive. As the breast pattern gets more dense, there's a masking effect. So we have a more difficult time interpreting the mammogram. And an invasive cancer can hide in the very dense tissue. Even with the best mammogram, which is what we're doing now with tomosynthesis, we still may miss these smoothly outlined masses that kind of hide in the dense breast. So we know masking effect is a factor, for the more dense patterns for us to miss cancers. But also, there's just an innate higher risk, that breast density has. And that's the other part of the equation, that the more dense the tissue is, it's an independent risk factor for breast cancer. So it's a double whammy. So when you compare women that have fatty breast tissue with women that have the more dense patterns, depending on the author and what you want to quote, you may get, numbers that are 4 to 6 times the higher risk when you compare them to fatty breast. It's more reasonable, as most of our population is in the scattered category. You comparing those scattered patterns to the more dense patterns, it may be 1.2 to 1.4 to 2 times the risk. So definitely there's a risk there when you're comparing it to populations that doesn't have as much of a dense pattern. So that's what we've concentrated on, how to find ways to offset that limitation that we have on the mammogram, even the best mammogram. So offering supplemental screening to those patients, whether it is breast ultrasound, whether it is contrast enhanced mammography that's kind of taking off right now, or breast MRI, if they qualify for that, given other risk factors. So it has been, work in progress. In New York State, we've had a mandate that says we have to inform patients since January of 2013 of their breast density. We have to inform the patient verbally and in a written letter in lay form, and also inform their primary care physician. So we're giving the patients the opportunity to converse with their healthcare providers and then come back for supplemental screening that we offer, which is breast ultrasound and MRI. So we've had the law in place for 10 years, and there's been a slow uptake of women coming back to have their ultrasound because they realize that's a risk factor for them. So it's been a slow go. The first year we had just a few hundred patients that their doctors brought back, but then information, education, and then consistency over time. As you tell the patients and the doctors, they're getting more information. So more and more patients are coming back. And now we have a very healthy screening ultrasound program for dense breasts. Some of those patients are also going to MRI because they have other risk factors for breast cancer too. But it is pretty healthy program, but it's taken years of education and information.
We'll circle back to that in a little bit. Now let's talk a little bit about Dr. Cusick, the Tyrer-Cuzick score, because that's it might sound like we're going, we've got breast density on one hand, we've got risk management on the other, but as we're going to be discussing, these two things are kind of coming together. Can you talk a little bit about the Tyrer-Cuzick score and kind of how it was developed and what it does?
Absolutely. Basically, we've been very interested in trying to prevent breast cancer, not only identify high risk, but do something about it. And we've done 2 big projects. One is taking high-risk women and offering them tamoxifen. And now more recently, with a postmenopausal woman, we've been offering them the aromatase inhibitor called anastrozole. And of course, the key to that is identifying high-risk women. We really found that their breast, the risk for breast cancer is fairly complex. We know more about breast cancer than we do about most cancers. So there are probably half a dozen to a dozen different factors which influence your risk. And it's really almost too much for people to really put together in terms of coming up with a risk assessment that's that accurate. So when we were doing this study, we actually developed the model to help us to decide who was at high enough risk to consider taking preventive therapy. And we took the basic view that if your risk was twice the population level, that was a reasonable estimate to be considering prevention. And 3 times, the evidence was really very good. So between 2 and 3, it's a little bit more of a personal decision. But we basically developed the model initially to help guide us as to who was at high enough risk to consider preventive therapy. Now it's actually now grown quite a lot and being used much more widely, not only just for preventive therapy, but deciding, one of the other big challenges is that, breast screening is given at a fixed time for everybody pretty much. And it's very clear that when you're high risk, you need more screening than not. And if you're at very low risk, you need less screening. And potentially, although this hasn't really been fully developed, if you've got really no risk factors and fatty breasts that don't have much density on it, I mean, it's an area of interest, but you need very little screening probably, and maybe you should worry about something else. But that's something that we're still developing.
Dr. Destunis, are you using the Tyrer-Cuzick score in your practice?
Yes, when I first met Dr. Cuzick and explained to him how important, his risk assessment model was, he was just like so surprised. He said, I didn't expect everyone to be utilizing it this, diffusely in the States. We use it all the time. We actually have software that's called CRA. And so all the risk assessment models populate. So we collect demographics on every single patient that comes through every time they come through our facilities, their age, BMI, history of atypical biopsies, family history, when they started menstruating, when they stopped, if they're on hormone therapy, all the information. And so it populates. And, most frequently the Tyrer-Cuzick model is so inclusive. We utilize that one because it collects the morphometrics. It collects the family history, not just of primary relatives. It collects all these very important things, the history of abnormal biopsies. So we utilize it because it's the most important model for us, because we are identifying that patient at risk, right? Anecdotally, we basically are basically knowing that patient is at risk. So now the Tyrer-Cuzick model is so much more inclusive. So utilizing the software that we have that actually is part of Volpara, which is our breast density software, vendor, we are able to, identify that patient accurately and then can offer them supplemental screening. And that's where, Dr. Cuzick has been so instrumental in helping us get there, because the Tyrer-Cuzick model is very, very helpful. And if people don't have the type of software that we have that's attached, it has its own server, but it's attached to our radiology information system and then populates our PACS. If people don't have that, they can download the Tyrer-Cuzick model. They can talk to Volpara about how to get it, but it's very important because it's made workflow seamless for us to identify those patients.
Dr. Destunis, can you walk us through the process that might happen where a patient comes through your door and I'm assuming that you do a mammogram, or how is the software applied? And if you do have a patient who has a high score, what sort of steps are taken then?
So the patient comes in, all the information is collected either online through the patient portal, all her demographics, her morphometrics, her history, and then it gets corroborated and double-checked when they come in at reception. They get changed and have a tomo, because all our patients have tomosynthesis. And then as soon as the mammogram is done, then the mammogram images get shipped over to the Volpara server that sits on its own, and then that gives it the breast density. That information is sent over to our radiology information system. Also, in the background, the software to do the risk assessment is working and populating all the models to see which one qualifies the patient for any additional testing or identifies that patient at risk. And then that information gets put together with the breast density. So Volpara does all that with us, and that gets shipped back to our own radiology information system, and then also populates our PACS system so the radiologist can see it. All this is happening through HL7 messaging in the background, but it's seamless. It's very quick. It will not work in a very busy practice like mine with multiple facilities. If I have hundreds of mammograms going on and we're at a dead still waiting for a breast density or a risk assessment, with our software, Volpara makes it very quick. The server creates a breast density that gets identified right away. Then the risk assessment models are all applied in the background. we identify which one is the best one for the patient. Usually it's the Tyrer-Cuzick, but not always. On occasion, it may be one of the other models, Klaus, Boadicea. But then, and that information gets put together with the breast density and creates a score for Tyrer-Cuzick version 8. And then that gets identified to the radiologist and goes back into our radiology information system. It creates a report for the patient. So the patient, before they leave, will say, you're identified at high risk because of these indications, because of breast density, because of your family history, so we tell the patient why they're identified at risk so they're not confused by it, because of your personal history, your family history. And then the doctor that referred the patient to us also gets this letter in more, medical terms so they can follow along of why we identify this patient at risk. And then it's up to the patient and the doctor to come back for additional evaluation.
You mentioned Tyrer-Cuzick 8, so there are multiple versions of, obviously the score has advanced over the years. Dr. Cuzick, can you talk a little bit about, where are we right now? Is Tyrer-Cuzick 8 the most current version? And what are some of the things, the risk factors that have been added to the score most recently to inform clinicians of a woman's risk?
Yeah, version 8's been going for a couple of years now, and it's really been quite satisfactory. We haven't had a lot of changes. We work quite a lot with some of the major groups, Manchester being one in the UK, to look at new factors. And there are a couple of things that we need to do. First of all, I should say that although the Tyrer-Cuzick model does ask a whole lot of questions, one of the things we often get is that people don't know the answers to all of these. And it's important to realize that if you don't have the answer to the question, you just leave it blank and it uses the population average. So it's not making it impossible to work with it just because you don't know a factor. The more you can put in, the better it is. But if you could just put in a few major things, you can get a pretty good answer. So that's one important thing. So we've been working on that. A couple of new things that have come up, which I think are been recent to the sort of understanding of breast cancer epidemiology, is that we've always used weight as a main factor, and weight's turning out to be quite complicated in the sense that weight is a very important factor for postmenopausal breast cancer, and it's actually slightly protective for premenopausal breast cancer, which is a little surprising, and that a better risk factor is to look at the change in weight from age 20 rather than just take your whole weight. If you're actually overweight at a young age, that's not good for many things, but in fact, it doesn't increase your breast cancer risk, which comes as a little bit of a surprise. And it's almost certainly due to the fact that in postmenopausal women, most of the risk factors that are important have got something to do with estradiol. And in fact, weight is being overweight causing you're in, particularly in postmenopausal women, all of your estradiol is produced in fatty tissue. And the more fatty tissue you have, the more estradiol you tend to produce. So that kind of explains a little bit what's going on there, that weight really is important, particularly only postmenopausal. It's more important there because it's driving the production of estradiol.
So what about breast density? When was breast density included in the model?
Oh gosh, that was I think that came in version 6 or 7, not so recently, because in fact until recently it was one of those things that was strictly a research area, and if you asked somebody what their breast density was or what a doctor to do it, they didn't know how to do it. So we put it in, I think, in version 7. Maybe, version 8 it became very, very prominent. It may actually only come in version 8.
I think it was in 8.
I think you're
because
right.
I actually did a review between 7 and 8, and the changes, how the risk changed based on including breast density or not, which we included in 8.
Interestingly, breast density turns out to be far and away the strongest single risk factor of breast cancer. So all the questions you could ask are telling you useful things, but in fact, you kind of double your ability to predict risk when you add breast density. So it really is an important factor.
So adding the density calculations to 8 probably really ramped up the model's
Exactly.
predictive ability.
some of the work we did actually showed that, yes, age is important, obviously, and being pre or postmenopausal is important. But when you do these regression analysis and you look, breast density is the only independent risk factor that just holds its own with Tyrer-Cuzick 8 for, the size of the tumors, larger tumors, whether it's a screening detected cancer or whether it's an interval cancer. Those are cancers that, show up between screening mammograms and tend to be hidden in the very dense pattern. So that makes sense that breast density would be a very important predictor for that. So we found that by using Tyrer-Cuzick 8, we were able to identify definitely changes between 7 and 8. And when I compared the two directly, it didn't affect the postmenopausal patients as much, but there was a lot more movement for the younger patients. Some patients moved into the higher category or moved out of the higher category. So the premenopausal women had more movement between 7 and 8. The postmenopausal women kind of stayed flat, and there wasn't as much movement. But overall, if you looked at the whole population of women, by using 8 and using breast density, we included more women in the high-risk category. And we were able then to identify them and educate them and offer them supplemental screening, whatever we had available, whether breast ultrasound, certainly MRI is the way to go if you have that available and if the patient is willing, right? So MRI was the right thing. And in those patients, then we actually looked at the patients that we identified, and the patients that went ahead and had MRI, out of the ones we identified as high risk, greater than 20% lifetime breast cancer risk, and compared the high-risk patients that did not have MRI to the patients that had MRI because we identified them with Tyrer-Cuzick 8, they had invasive cancers that were detected, they had smaller cancers, and they had less of lymph node metastasis. So the high-risk group women that were identified actually had MRIs did better than the high-risk women that did not have MRI. And breast density played a significant role there.
How important, Dr. DeSunes, how important is it having this model in a software package? And you kind of touched on this a little bit earlier, but you said that there would be no way that you could calculate all these things
right.
By yourself.
Back in 2009, we tried to do this on our own with paper and our nurse. So we assign a physician a day to sort of try to identify the patients with the nurse and then talk to them. We had to send them out to have their back to the gynecologist or primary care physician. And if they agreed, they would go for genetic testing and the blood was drawn somewhere else. Then we get the results and then the gynecologist discussed them with them because they didn't want us to get involved. It was overwhelming. We spent all our time and only could talk to a few patients a week. And so it wasn't, what we do. What I do is detect breast cancer. I am a great interventionalist. I do biopsies with all modalities. I read mammograms, ultrasound, MRIs. Sitting down and talking to a patient about the risk, it took me hours and absolutely got nowhere. So when we hired a genetic counselor and then dedicated staff to help her, and then we transitioned to the Volpara to help us with the risk assessment evaluation, populating all the more up-to-date risk assessment models, and also now incorporating breast density, and it's all been seamless. It's a life-saving for us. We're able to identify, thousands of patients a year that could benefit from a discussion with their genetic counselor, genetic testing that can benefit from yearly MRIs. We're finding thousands of cancers in those women that we're labeling as high risk. So if you can do it, it's so important to do it. But you cannot do it on your own with paper. You have to have some kind of software option to be able to make this seamless. Otherwise, you'll never go home and you'll drive yourself and your staff crazy. So this has been a life-saving for us. We're very thankful to Volpara for helping us.
One of the things that's important, I think, as well, is that we spent a lot of time validating our model on a range of different studies, and both in the United States and in the UK and elsewhere. And some of the models originally were where they put in risk factors, but they weren't that reliable and predictive. We've actually found that our model just holds up extremely well in terms of long-term follow-up and different studies in terms of being able to predict things. There are other things that we could do. We still probably need to do some more work on minorities where the risk factors are a little bit different. And we're thinking about that. The other thing that we added in version 8, which hasn't really taken off so much, is to do a SNP score. We know not just look for the main breast cancer genes, the so-called BRCA1, BRCA1, and BRCA2, but there are now 300 genes which individually slightly push your risk up or down. Individually, the risk changes are 5% or something, not enough to worry about. But when you have, and we typically look at, over 100 of them in that. When you have them all together, you actually do get a nice prediction spread of risk, which seems to be about as valuable and powerful as breast density. So when you put the two together, that's an area where there is scope for change and gain. It's not straightforward because you do have to get the blood sample and do a genetic test. So it's not for everybody, but when you're moderately high risk and really want some clarification, we found people are very happy getting that done, and it does work. It actually adds useful information.
And the important thing here is that it's not just BRCA1 or 2. When you do have a risk assessment department, you're looking at multiple different genetic mutations that offer you a higher risk for breast cancer. So now we realize that some of the other genes are so very important. PTEN, PLB2, things that we didn't think about before. So you have some moderate penetrance genes and even the low penetrance genes, and with enough risk factors and the breast density together, those have become very important. And we're identifying patients that are at risk for breast and ovarian, melanoma, all the other cancers that run together. So you're really offering the patient kind of a comprehensive risk assessment, so that's so very valuable for prognosis for them long-term and for life-saving. And, if there is a breast cancer or another type of cancer, it's found early where the treatment is so less toxic and so much more, easy to deal with for the patient.
Now, Dr. Destunis, you've researched the value of volumetric breast density in the Tyrer-Cuzick 8 model. What were your findings? Can you summarize that real quickly? And what about the role of volumetric density in predicting tumor size?
So volumetric breast density, we found really correlated and supported very well, better than the visual BI-RADS. So most physicians, when they look at a mammogram, they assess a category. By using the software from Volpara and actually having a volumetric breast density, we see that everything is kind of on a continuum. So every heterogeneously dense breast is not the same, every extremely dense breast. So you have a lot of variability, the low heterogeneously dense versus the more high heterogeneously dense. The sensitivity and the breast cancer concern is different. So we found with volumetric breast density that actually it was a very good predictor, for breast cancer and for also the greater than 2 centimeter tumor size. So the higher the volumetric breast density, the more the risk of missing the cancer and finding the cancer was a lot larger. It makes perfect sense, but it actually correlated much better than our visual BI-RADS. What we assess as the breast density category, it was a much more accurate way of assessing breast density. And we identified these women with the bigger tumors for screening detected cancers and also for the interval cancers that occur in between years. So that was very important for us to detect. We also found that some of our low heterogeneously dense, the sensitivity with mammography is still very good. So there's this great variability as you move into the heterogeneous dense pattern and get to the extremely dense. So the sensitivity for mammography decreases and breast density increases, obviously. And the fact is that the masking risk increases and the risk for the patient for breast cancer increases.
I do think you make a really important thing is that that the proper measurement with volumetric density is much more relevant than BI-RADS, which is, of course, it's a personal measurement, so it's not that reproducible between people, and it's missing a lot. And it's missing a lot of the information. So, it is still substantial. It's better than nothing, but it's nowhere near as good as as a proper volumetric measurement.
You know, there was a study from greater than 80 radiologists that was done, and the variability of like calling something heterogeneously dense was 6% to like 85%. So there was such a huge variability in what radiologists call dense. And we did it on our own because, you know, radiologists, it has to be proven to us that something is good and effective. We don't agree to things too easily. So my own partners, we looked at a series of mammograms and assigned breast density. We agreed with each other about 75% of the time. We agreed with Volpara about the same, 75% of the time. But we looked at the same cases a month later, and we didn't even agree with ourselves. Like, we disagreed with our own breast density assessment of a month ago. So we were like, wait, what? So we disagreed with ourselves and then with each other. So whatever we assigned a month ago, we didn't agree with. And it was always the BC, right? Because we tend to agree on the A's that are predominantly fatty. You know, some of us may overcall them, trying to get them into a B, but we agree for the most part. And we all agree on the extremely dense. But the B's and C's, the heterogeneously dense and the scattered, we disagree with each other. We disagree with ourselves. So we definitely need a software solution that's consistent and reproducible like Volpara. It takes that out of us, and we can trust it more. It's more objective. We're very subjective when we assign breast density.
Yeah, excellent. Well, we're about out of time. Anything that we can look forward to, Dr. Cusick, in terms of the model in coming months or maybe the next year?
Well, I think we've been looking at, there's sort of three things. One, I was telling you about the fact that in fact the volumetric density is clearly better than a visual. And secondly, the fact that we've been looking at in many places that have data, being able to look at more than one mammogram, looking at the changes in density over a couple of years can actually be quite helpful in terms of predicting risk. So we may well add that into version 9. We're talking about that. And I said a bit about weight. Those are probably the new things. There's a lot of interest in this volumetric density as well, but in our experience, which is not huge, but other people seem to find the same thing, is that volumetric density really tells you something about the risk in the next year or two. And it's kind of picking up lesions that are actually visible, but not that easy, and you need a complicated system to see that. Whereas the volumetric, whereas density itself is telling you not only about lesions that are there now, but a situation where the breast cancer is more likely to develop over a period of time. And it turns out to be a very good predictor for risk at 5 and 10 years as well, not just a 1 year, whether you catch something a little bit earlier that you missed, but really new things that weren't visible previously. So those are the things that we've been looking at.
Great. Dr. Distunis, what can we look forward to seeing from you?
Well, you know, we're working with the volumetric density, just like Dr. Cusick said, and we're going to continue to develop, you know, our high risk program. And, you know, we're looking at breast MRIs that we've done in a high risk population, actually. And this is something I'm presenting at RSNA. And we found that for the women that actually got to genetics, got to the risk assessment evaluation and had the MRI, and we've looked at 5 years worth of our data, those women actually ended up having breast cancers that were smaller. And the burden of tumor was a lot less. So we're going to continue to work with that, and also just look at the continuum of volumetric density and see how we can better assign risk to patients, and look at the 2-year risk, like Dr. Cusick said, and 5-year risk and the 10-year risk, and see how we do. And, you know, we're really excited about where this is going to take us, and how, and now that all of the United States has to inform every patient about their breast density, you know, by September of 2024. The states that had no breast density mandates or laws to inform patients or their doctors now have been given their marching orders. So I'm looking forward to that, because in New York State, we kind of were ahead of the game. You know, Connecticut, New Jersey, we're early on. And when I give talks all over the country, everybody's like, we don't have a law, we don't have insurance coverage. So all these states now have to conform to the FDA and MQSA mandate. And we have to find ways of explaining this to patients, educating them, offering them supplemental screening, and find some way to pay for it. So this is an exciting time for us because as a clinical radiologist, I'm excited to provide all this to patients, but I don't want to add more stress to their lives by telling them of a study of an imaging test that they should have because they're at risk after I identify them, but then they cannot afford it. So I'm looking forward to looking at the politics and the advocacy that's going to happen now for the next year or so we can pay for these very important tests that we should be doing to identify these patients at risk. So I think breast density it's going to be exciting, and we'll see where our risk assessment takes us. And I'm looking forward to seeing all of it.
Definitely. It's going to be a really exciting year to come. Well, Dr. Jack Cuzick, Dr. Stamatia Distunis, thanks so much for being with us today. It was a fascinating discussion, and I'm sure all of our viewers really appreciated it. Thank you for being with us.
Thank you for the opportunity.
Thanks. Happy to talk.
Signing off for the Imaging Wire, my name is Brian Casey.